C'est bon, on y va, Cécile?
Oui.
So, hi, everyone. My name is Mark Stebbin, and I'm the president of IUSTI Canada. And I welcome you to this webinar about what if the next pandemic was an STI. In Quebec, we're happy to have the expertise of Dr. Cécile Tremblay. Dr. Tremblay is a medical microbiologist, an infectious diseases specialist at the Centre Hospitalier de l'Université de Montréal. She is the director of the Pfizer University of Montreal Chair on HIV Translational Research. She set up two pan-Canadian cohorts to study the determinants of disease progression, including premature aging phenotypes associated with HIV. Our research program also includes studying genetic viral evolution and its impact on viral entry and drug resistance, as well as pre-exposure prophylaxis. She has recently developed several research projects related to COVID-19, and she has been a predominant figure in the media throughout the pandemic. And following up on her COVID expertise, she wrote a book that was published at the edition of La Presse, and it's about being ready for the next pandemic. The book is on sale, and Cécile was agreeable to talking about her book about being ready for next pandemic, but what would happen if it would be an STBBI? So I'm very happy to introduce Dr. Cécile Tremblay. Cécile, please.
Thank you, Mark. I must admit that the technical difficulty that we have is that my presentation file was corrupted, so I couldn't open it. So we will talk. We will discuss a little bit about the theme, what if the next pandemic was an STI? And I think the first thing that I want to raise is the fact, well, there was another pandemic that was an STI that occurred in 2022, monkeypox. And this is just to illustrate how we never know where it's going to come from. So in this particular situation, it is a disease that was known, that was occurring in certain very known geographic. Oh, these are my disclosures. I'm sorry, I should have shown this at the beginning. It was known in certain geographical area. And I will have to go through, don't worry if I run the slides very quickly, because this is not what I want to focus in. Because I'm using a slide deck that was not for this particular presentation. So it's been known since 1970, and it had been localized in Central Africa and West Africa. And suddenly it jumped to another completely different area and mode of transmission. So I give this as an example just to show that although we are used to think of pandemic as influenza or respiratory viruses, there can be very many different zoonosis or different entry into the human species that could create another pandemic. And one of the things that I illustrate in my book and that I discuss is that we need to have a holistic approach to preparedness for pandemic. What we are doing to our environment, such as deforestation, such as the creation of a very dense populated region, very close to the forest, are and the réchauffement climatique are. All of these are conditions that are amenable to a new zoonosis. So when we want to talk about preparedness, we need to think about it in terms of everything that we can do to be prepared, and not only in terms of drugs that we can develop or vaccine that we can develop, but the socioeconomic conditions that we have around the globe and the climate environment are as important in terms of preparedness as the medical approach that we need to develop. So monkeypox is an example of a disease that is transmitted through contact, direct contact. But in the case of the recent pandemic, it turned out that it was transmitted mostly through contact, through sexual contact, and although we cannot necessarily qualify it as an STBBI, we know that it can be the mode of transmission for a next pandemic can be unique and not necessarily what we had in mind. Also, the title of the talk was a little bit interesting to me because we're talking as if the next pandemic would be an STBBI. But let's remember that HIV is still around. It's still a pandemic. It's still, there's still 1.5 million new infections a year. And we completely forgot about it during COVID-19 as if it was inexistent, as if the only pandemic was COVID-19. But it's still around and it's still an STBBI. And so it is very easy to imagine that another virus or another bacteria could emerge and be transmitted by blood or by sexual transmission. So with this in mind, I mean, I think we need to look at what we did with the COVID pandemic and see what lessons we can learn of what we did well and what we didn't do well to prepare ourselves. And in the book, I mentioned the good things that we did and the bad things, the things we didn't do as well as we could have done. So what are the good things that we, so how do we define a pandemic? So many people say right now, oh, COVID-19 is behind us. We're not in a pandemic anymore. We're in an endemic situation. But I beg to differ a little bit because if we define what is endemic, usually it refers to a situation where the disease is present in the general population, in the specific population, specific area, with a stable incidence. So you don't see very high peak of transmission. So the waves, we don't see the waves the way we've been seeing with COVID-19. And although the situation is calmer right now in Quebec and in Canada, we see that we still have variants that emerge and that are very transmissible, and they tend to evade some of our treatment, like monoclonal antibodies. And we don't know yet if we're going to see a new variant that's going to be cause a higher mortality rate or more severe disease in the next future. And if we think of COVID with the XBB1 that is becoming predominant in the US and now in Canada is having a bigger share of the market, we see that there is going to be a lot of infection. Now, what we did well with COVID in terms of the pandemic is the effort that was done early in the pandemic to put a group of organizations together that led to the development of a vaccine very, very quickly compared to other disease that we're still struggling to get a vaccine, such as HIV. So that's one good news, one thing that we did well to prepare for a pandemic. And what was the difference with this disease compared to other disease where we're still waiting for vaccine? We've been waiting for ages. For example, gonorrhea, we're still waiting for a vaccine. Syphilis, we're still waiting for a vaccine. Chlamydia, we're still waiting for a vaccine. HIV, as I mentioned before. But the difference with this pandemic was there was like billions of dollars put on the table and a commitment of various governments, philanthropic organizations, pharmaceutical companies, because they recognize the urgency of having a vaccine because the virus was killing people, was very, very lethal. Excuse me. So, and these efforts were successful. So we have the vaccine now. And of course, even if we have increases in transmission because the new variants are more transmissible, because a large portion of the population is vaccinated, so the consequences are not as bad. People have less severe illness, less hospitalization, less mortality. So, but even in the case of a situation where we have a vaccine that is effective, although not perfectly matched with the variants that are circulating, but still good enough to protect us against severe disease, the distribution of the vaccines are not equal around the world. And it depends a lot on the socioeconomic conditions. So again, if we were to develop vaccines for other diseases such as HIV or gonorrhea or chlamydia or syphilis, we would need to make sure that the distribution of those vaccines would be equal around the world. And that's not a given because we know how long it took just for the antiretroviral to be available to people living with HIV in Africa. So we have a lot of challenges in preparing ourselves to a new pandemic. And so the idea of the medical discoveries, such as vaccines or treatment, needs to be put in the context of implementing these new technologies and making sure that they reach the entire planet or people affected with these new disease. So, this is for the vaccine. Now, we saw that during the holidays, we had not only COVID, but 2 other respiratory viruses at the same time, respiratory syncytial virus and influenza. So that's another concept that we need to think about in terms of a new pandemic with STI. It could be that a new pandemic would be a combination of pathogens that could affect people in a different manner. We all know that if there were another STI and that the people, for example, living with HIV would be probably affected differently than other group of people, and so we need to have healthcare programs that are adapted to treating several problems at the same time. So again, this holistic approach, not only in terms of society, but in terms of the individual, is important in our planification for a response to various pandemic. And usually it's not necessarily the strength of our healthcare system, although it should be. So the more we can develop healthcare systems that are based on a comprehensive, that are patient-centered with all of its of the patient's strength and illnesses, the more when a pandemic arrives, we can organize a response that's going to be holistic. And we saw during COVID how much HIV patients were left out. There was less testing for HIV. There were less prophylaxis for HIV PrEP that were given, that were prescribed because of the isolation of people, and because instead of increasing access to care during a pandemic, the access to care was decreased. So it is something that we had not planned before, that a pandemic could affect the healthcare provision because of the confinement, because of the isolation. So if we think of a next pandemic, of course, it's going to be more acute if the virus is a respiratory virus, or if the transmission is very intense, such as with these respiratory viruses, which might not be exactly the same for an STI or an STBBI. But we still need to think that there might be factors that would decrease access to care with these other pathogens, these newer pathogens. With COVID-19, there might have been some stigma at the beginning, but very quickly, because it became so rapidly affecting almost everybody in the population, whether they had the disease, they knew somebody who had the disease, who had died from it. It was affecting the healthcare systems that were collapsing everywhere at the beginning. People didn't feel as the stigma in terms of being ashamed of having the disease or something like that was not very prominent with this type of illness. But if the pathogen was an STI, the new pandemic, there would still be this stigmatization, because most often people with STIs are being stigmatized. And so in that sense, it would prevent them to seek care, and therefore it would probably increase transmission and it would delay the identification of the new pathogen and the measures that we would be able to take to prevent its transmission and develop eventually tools, either antibiotics, antivirals, or vaccines against these new pathogens. So in terms of infrastructure, what we've realized with COVID-19 is that if we don't have local infrastructures to be able to assure a minimal access to whatever we need to deal with the pandemic, such as, in the case of COVID, it was masks that we didn't have, it was the gowns, it was the medication, it was at the beginning the vaccine. We are less well equipped, and the longer we take to put these measures into effect, the greater the transmission occurs, and the harder it is to limit afterwards. So one of the conclusion was, and these were lessons that had been learned from the influenza pandemic in 2009, that we should have the infrastructure that we need to produce vaccines in Canada. And this wasn't put into practice before the COVID pandemic, although it had been clearly identified as a lesson learned from influenza. So we don't learn a lot from the experiences that we have in the past, because not only didn't we have the facilities to produce vaccine in Canada, But we had the pharmaceutical companies who were producing vaccines or drugs had left Canada. We had left head offices of the various companies. We had less than we had before the influenza pandemic. So when it came time to vaccine production, we were dependent on other countries. Of course, will prioritize their own population. That's kind of logical. It's not the thing to do, but it's understandable that people would do that. So again, it delays the capacity to respond adequately. Same is true for manufacturing drugs that could be efficacious in a pandemic, and good decisions were made during the pandemic. So now there is a program in Canada, and facilities have been are starting to be put in place to produce vaccine. We now have Moderna that is opening a center in Quebec, and they're producing different kinds of vaccines. But there are other facilities as well. So that's a lesson that I think is a positive lesson that was learned, and that we need to continue and not just drop the effort once we feel that COVID-19 is behind us. The communication is a very, very important aspect of how to manage a pandemic. And I would say if a pandemic is an STBBI, communication is even more important because of the stigmatization that I was referring to before. We had an issue with monkeypox in terms of how do we communicate? Are we alarming the entire population, and are we giving the same public health message to the general population, or are we targeting our communication strategies to the populations that are most affected? And this was a decision that was a conscious decision to decide to concentrate the communications effort to the populations affected, because they were the most at risk of acquiring the disease. And this is the first thing that you need if you want to control a pandemic. You need to start with the people affected. And because the spread was a contact, the mode of transmission was contact, then you have a little bit of time in front of you. It's not as if it was a respiratory virus and the transmission is extremely intense. So, and I think it was the right decision to decide to concentrate the communications to the population affected and concentrate the intervention to the population affected. And that, in this case, we had a vaccine that had been shown to be effective in very limited studies in humans, but enough to think that it would have an impact. And in Canada, we were among the first to offer the vaccines to people in the affected communities, and with a very good uptake. And that proved to be a very good strategy, because we were able to stop the not completely stop, but to decrease the transmission more quickly than in other areas around the world. So communications is key. You want to avoid panic, but you need to inform correctly the entire population, but you need to be very specific to populations that are most affected, so that we can give them the tools to protect themselves very quickly. Communications, there are things that we need to learn better in terms of false information and misinformation. So we saw with COVID, how much there was, although the public media, the traditional media did quite a good job in terms of reporting the correct information, having expert discussing the guidelines and the recommendations of public health quite regularly during the entire pandemic. But we were much less efficacious in social media to counter the misinformation that was put forward by anti-vaccines group and other groups. So what have we learned from that? If a next pandemic would be an STBBI, this misinformation might even take a bigger place. So I'm not sure that we have developed the appropriate tools to be able to counter this misinformation in social media. Some experts have become more influential on social media. There has been a diversification of the various platforms that can be used to provide the good information, but we're still behind the people who are producing misinformation, and this has a very great influence in terms of affecting the credibility of our public health messages. So I spend a lot of time with communication, because communication is probably the key to controlling a pandemic, besides the biomedical tools that we can or cannot develop to control a pandemic. Let's not forget that it might be, the next pandemic might be a pathogen for which we don't have any tools. We don't have drugs, we don't have vaccines, and then your only method to control are the traditional public health method, which are quite effective in terms of preventing contact and preventing transmission. So in that situation, communication is the major tool that we have at our disposal, and I think we need to do more to improve our capacity to counter misinformation. Now, other lessons that we learned from COVID pandemic, and we're not very good at implementing them, is that we realized that the healthcare system had weaknesses that were endemic. The elderly and the nursing homes and the CHSLD in Quebec, we knew for a long time that they were not adequate, that the ventilation infrastructure was not adequate. We still had places where there were 4 patients per room. They were not equipped with the necessary equipment to protect the healthcare workers. We knew that there was a lack of healthcare workers at all levels: nurses, nursing aid, des préposés. And although every government from one after the other were saying, oh, we need to improve that, we're going to create these new homes with all the features that are necessary, but still, since all that period, there's only one of these new homes that has been built in Quebec, and the others have not improved at all in their ventilation, and there have been a few changes, a little bit more personnel, but we're still in a situation where there is a lack of personnel almost everywhere in the healthcare system. So if we have a new pandemic, this hasn't been fixed, you know, and one of the problems is that the management of the healthcare system is unfortunately dictated by politics. People have a 5-year agenda until the next election. So it's very hard to implement major changes in terms of the brick and mortar. So we need more facilities, we need to staff them, and it takes a lot of money. And we're not investing as much money as we would need in these infrastructures in order to be able to better be prepared to confront a new pandemic. Now, of course, probably the nursing homes and CHSLD and these type of facilities would be less it's not where the situation would be the most complex in terms of an STBBI pandemic. But then we have other population that would be predominantly affected, for whom the social services and the healthcare services are not appropriate. We have all of these populations where we have substance users, we have people who live in the streets who are not well served by our healthcare system because of a practical constraint, but because the focus hasn't been there enough. Although we've all lived the opioid crisis, it's not over. We still see a lot of people dying every day, and this is a pandemic as well. So how do we put the effort in terms of strengthening the offer of services to these populations who are the most vulnerable in our society? So if we don't fix this before a new pandemic, they are the ones who are going to be the most affected by any pandemic, whether it is an STBBI or whether it is a respiratory virus or another kind of virus or pathogen. So I think the message that I wanted I was trying to convey in the book and in the reflections that I had from COVID pandemic was to prepare for a pandemic is not just to think of the pathogen itself. It's to think of our healthcare system and our society as a whole. And the more we improve the healthcare system as a whole and our relationship with each other and with the animal world and with the environment, the best we will be prepared for a new pandemic. I'm just going to see. I'd like first maybe to see if people have any questions or comments or maybe things they would like to discuss. I will only add that whatever biomedical discoveries that we make, there is always limitations. And I will take, for example, the monoclonal antibodies that we've developed for COVID-19, and most of them are not useful anymore because the virus have beaten us to us. So we need to remember that although a lot of effort needs to be done in that area, the basic principles of public health remain the cornerstone of controlling a pandemic, and that we should not forget that in our preparedness plans.
Thank you, Cécile. We have a question, and it's about when you talk about infrastructure and stigma, how do you think data collection plays into this? Being able to collect detailed case data for STBBI can be very helpful in identifying key population and providing tailored intervention. But when it comes to STBBIs, there may be even more resistance to providing or collecting this information.
This is a very important question because there is a debate right now in terms of we need data to inform our decisions, and we need data to inform not only public health decisions, but management decisions, and eventually developing curative approaches and everything. So for me, data gathering is very important, and we have ways now to be able to collect data in a secure way, so that it can be used by researchers or by public health authorities to be able to inform their decision. Unfortunately, there is resistance. Like in Quebec presently, there has been a law that has been passed. That is, they pass only like half of the law. And now, because La Commission d'accès à l'information has a certain interpretation of that, they're blocking any research that we can do by just chart revision in our different institutions. Things that we used to be able to do very simply by asking, permission to our ethics board and everything. So now we can't even do that. So there are extremes both ways. We cannot go around and spread personal information to everybody, and everybody is very conscious of that. But we cannot also say, because there is a confidentiality issue, prevent any data gathering. I think it would be very ill-informed. So we've been in HIV, we've been gathering data for years. We have cohorts for whom we have documented all kinds of variables, and that we can use, and that have been very useful to inform our research and our public health decisions. And we've been able to do it with preserving the confidentiality. And when you explain it to the person, to the participant, they were more than happy to share. Let's not underestimate the altruism of the population that are affected by these diseases, because they know that research is the way to find a solution. So I think it is very important to gather data and to develop newer ways to gather data. And there is the traditional way, but there are also now new ways with social media to be able to question these applications. And so I think it is very important. And unfortunately, we are limited right now in what we can do.
Thank you. There's a question about the staff. You mentioned that there were issues with insufficient staff. What would be steps that should be taken to make make available appropriate number of staff during a pandemic?
Well, during the pandemic, you can only try, Band-Aids. So what they did was they asked people who had retired to come back and do the vaccination clinics and everything. And then they made a general appeal for people to be trained as préposés aux bénéficiaires, to the general population. And they offered incentives such as money and a guarantee of a job. So these are all kind of approaches that can be used that are temporary, because you don't solve the fundamental problem of a lack of staff at the, so one thing that would be important would be to improve the training and the conditions of people who train in the medical professional different categories, nurses, technologists, and to make sure that they graduate enough people to be able to staff the institutions. But one of the problems that we see, for example, in Quebec, is there is une fuite, like the nurses are leaving the public sector to go to the private sector. Which is a big problem, because they are vase communicants. So if you have a certain amount of nurses, if they go to the private sector, then you have less in the public sector, and the bulk of the care is in the public sector. So there needs to be, in my sense, we should not promote the private sector because our healthcare system is a universal healthcare system, and we should focus on solutions to make sure that the staff is well treated in the public sector so that they can entice them to stay there and have long careers. You can also try to recruit internationally, but every country has the same problem, so we're still in the same. So there is a need to valoriser the professions, to attract more people. There is a need to make the training more easy and to give, in my opinion, scholarship so that it is free. They don't need to pay to study, and then you probably will have more people entering these programs.
Thank you. Someone is asking, can you speak a little bit more about the intersection of STI, zoonotic, and climate change? We often think about Lyme disease and tick movement, but are there others we should be thinking about?
Yeah, so I think I just like to take monkeypox as an example. It's not really an STI, but it becomes very close to an STI because of the way it was transmitted, and it wouldn't take a lot for another pathogen to follow the same route and becoming really an STI transmitted by sperm or vaginal fluid or anything. So monkeypox comes from the fact that people in these various regions live closer to wildlife because of deforestation. And it's not only monkeys, actually, it's more those, how do you call them? Les rongeurs, the
rodents.
Yeah, rodents, but prairie dogs and these types of rongeurs that are implicated. So the closer you live to wildlife, the more likely you're going to have disease transmitted by animals to humans, and eventually they can spread. So and we talk about STBBI, so spread by blood also is a mode of transmission. So think about Ebola. So we're all very concerned about Ebola because Ebola is so lethal that if it were to acquire another mode of transmission than what is direct contact, what we know so far, then it would be a catastrophe. So Ebola, again, is a zoonosis. So it has, and if we think about the pandemic, the epidemic, but it had 5 countries. In the 2013, it started because there was a person who acquired it in a village, and then they went to the other village next, where there was big highways it was a way where there was a lot of traffic. People were going back and forth, and that was the major way it was spread. So it was very close. The village in the forest was very close to very dense human activity. So again, the closer we live to wildlife, the more likely we are to see more zoonosis that can be transmitted through any kind of ways.
Thank you. There's a comment about communication seem almost contradicted between entities. So sometimes the WHO would come with something, public health agency, provincial or local expert. How can we prevent the communication to be so mixing for the population? There seem to have been even too many communication at some points.
It is a challenge. You're right, it is a challenge. And ideally, the major public health components should talk together and discuss their public health messages and have a common message. So that would be the ideal. Unfortunately, it's not as simple. WHO needs to consider the situation in very various contexts. So the message might not be the same or ideal in a very highly industrial country than a developing country. And they have to be mindful of that. So usually their messages are broad and late and, not that, not as useful as we would like. But if you're in the same country, you should try to adjust your message so that everybody say the same thing, the same truth that we know at that time. But we have to be very cautious to be able to always nuance what we're saying with the level of knowledge that we have at the moment, and teach the population that science is a moving thing and things might evolve, and we might not be saying the same thing next week if something new has been. And this is a very difficult message to convey to the population. And although we've tried to do it, I know that I was a lot in the media, and I tried to always say, okay, this is what the best decision for now with what we know, but it might evolve and we might do something else next week, So this is very difficult. And sometimes it might seem contradictory, but the clearer we are in the nuance that we give to our message, I think the better we are. But it is a difficulty because we have to be nuanced, but we also have to be very clear and the population needs to have clear guidelines. So they need to, the message has to be specific enough so that people know exactly what you want them to do. But at the same time, a layer of nuance. So it's hard. It takes communication between public health authorities to try to, and then the experts, you cannot control what people are going to say. So people might have different opinions, and it's the responsibility of the experts to make sure that, well, although they are very free to express their opinion, well, it's not an opinion, it's based on scientific data. So I was always mindful of, even if I was not like 100% completely in line with what the public health authorities were saying, I tried to take whatever I was agreeing with and make it the public message. And it's not the time during a pandemic to try to highlight the negative part, because then you're confusing everybody and nobody's going to listen to any message.
There are two questions about misinformation. So misinformation was very present. I think that we never had so much misinformation going on at the same time. Should we be answering misinformation, or should we let go the information? So there seem, when you answer, it gets even worse. It amplifies. What's your opinion about misinformation?
Yeah, I tried not to answer misinformation directly, because you're right, it kinds of amplify the problem. I think the best way to address it is to make sure that the content of the good information is spread broadly enough to compensate. Of course, you can have a few sites that will answer, myths and reality and do fact checks on things. That's also, you need this as well. But the major part, I believe, is the space. And the problem is that the space in the social media, there's money behind this. There are people with money who are buying play to make sure that they're in the algorithm, they appear the first or the second. So we need to be more mindful of that and have a strategy to address this, to make sure that the good information is ranked higher in the algorithms of these social media. But I agree, same thing for anti-vax people. There are a lot of various, it's a heterogeneous population, but so some people you can listen, everybody, you need to listen to them, understand what their concerns are, and respond specifically to what their concerns are. But the people who are really, it's like, almost like a religion, then there's no point in wasting your time trying to contradict them. They're just going to make them even more resentful. So it's better just to let go and make sure that the good information is provided to enough people that it's going to win over time.
There was a second question about misinformation. What would be the most important lesson that you've learned about misinformation management during the pandemic?
Well, I think one of the sad things that occur when there was the convoi, the truckers who invaded Ottawa, was that because it happened that the wave was decreasing and some of the public health measures were diminishing, the interpretation that these people made on the social media was that their action, that this was the consequences of their action, giving them more power. And I don't think we responded well to that. And I think the problem is that if you don't talk, then somebody else talks. And so the same way I feel that right now we're not talking enough about COVID because everybody want to keep it behind them and want to go to somewhere else in their life and everything. We've stopped completely commenting on it in the media, so that there is a lot of room for misinformation. So, it's hard to point out one specific aspect of it, but I think that the governments and the public health authorities should have a strategy, reflect on a strategy that is very well defined and precise on how to increase the public health message in the social media sphere. And I don't think we're mastering this at all right now.
And as a last question, I'm putting you on the grill. Will we be ready for the next pandemic?
Oh, we're not. We're not ready. We're not ready. We haven't done anything of what I was saying. Depending on which population, you have to think who's going to be the target of the next pandemic. So which population? So we need to have pandemic preparedness plan adapted for any potential population that's going to be the most targeted, which we hadn't done before. So in this case, it was the elderlies. But if we think STBBI, it's going to be the younger folks. And if we think substance abuse and opioid crisis and everything, it's going to be all these vulnerable patients. Do we have plans adapted for all of these populations? We don't. And do our healthcare system, is it strong enough for a new pandemic? Of course not. We're lacking nurses, staff. We still have waiting lists in our emergencies, waiting lists for our surgeries, for the normal situation, so let alone a new pandemic. We've done progress on the vaccine facilities, so that's a good point, but we haven't brought back the pharmaceutical industry to a point that we could be highly implicated in developing new drugs for new pathogens. Certainly not enough. We have done a little bit of improvement in the capacity of producing ourselves some equipment, but we're still relying on China for most of it. So we haven't done that. So, and these were things that were in the pandemic preparedness plan of influenza 2009, and we still haven't done it. We have one new Maison des Aînés in Quebec, which is the nursing homes with extra care. And they had planned to build 12 of them, which would be, even 12 wouldn't be sufficient to take care of them properly. So no, we're not ready.
So what do we do next?
We get ready. we try. There are committees out there. One of my suggestions was to have an independent committee, not necessarily completely independent, but a committee, like a group of people whose function would be only to monitor once we've written the preparedness plan, but we shouldn't take 2 years to write it because we know what needs to be in this plan, but to make sure and to have the power to check on the various authorities in the government and the Ministry of Health. Where are things going? Every 6 months, for example, how many new nursing homes have we built? How many facilities do we have? How are we in terms of the personnel? How are we in terms of the communication strategies? So people need to check that. You cannot just write a plan and leave it on the shelf for the next 5 years. And that's what we did last time. So and public health authorities have enough work just to do the work day to day of the ordinary life, that it's not, it should be given to a group. They could be part of public health, but there should be a specific group of experts in these various functions that would be in charge of making sure that these plans are put into action.
Thank you, Dr. Tremblay. Very well appreciated. I think it was interesting to hear about your thoughts, having been in the center of discussions in Quebec province. I would like to remind people that we will have a webinar at the end of February, and it will be on PrEP. We will have one in March, and it would be the issue of pleasure in our prevention program. Where does it fit to help us prevent stigma? And we should have one in April about different microbiomes of the human body and their interaction with STBBI. So thank you all for being present, and we will make sure to have the copy of the webinar available on IUSTI Canada website. And I would like to remind you that the inscription to the World ISSTDR IUSTI meeting that will be held in Chicago in July 2023 is opening for registration. So make sure you make your hotel reservation in advance. So thank you all, and talk to you in about a month for the PrEP webinar.
Apologies